Hello, this is Carla. I'm going to be finishing my musculoskeletal lecture for y'all. This is not my ideal way of giving a lecture because I don't like talking in front of a screen with no audience, but you're just going to have to bear with me. So I've got my book open. I'm going to start reading excerpts from the chapter. I'm just joking. I'm actually going to just kind of go through this musculoskeletal PowerPoint. If you have a patho map in front of you, that might be, or a blank patho map, that might help. I know we've hit on a few of these things, but if I just want to kind of touch on some of the main points again, and also talk about low back pain and rotator cuff injuries, which is one of the things we did not get, and osteomyelitis, which are the things we did not get to talk about in class. So, musculoskeletal system. We talked about osteoporosis, I think pretty thoroughly in the last Integrity. Y'all can re-listen to that if you need to. We also briefly touched on hip fractures and other fractures, and femur fractures and joint replacements, but those middle three, osteomyelitis, low back pain, and rotator cuff, we're going to talk about further. So we already went over those slides. If you have questions, you can refer back to the old Integrity. Let's start here with hip fractures. We talked about how hip fractures happen most frequently in elderly people, specifically those that have osteoporosis. We talked about how there's a high mortality rate 1 year post-operative, that a lot of times people who have hip fractures end up dying within that first year to 5 years, mostly because of the complications of having hip fractures, such as immobility, which can lead to DVTs and pneumonia and things like that. The different types of hip fractures are intercapsular and extracapsular. This is a picture that shows the intercapsular area, which includes the head and the neck of the femur. The problem with fractures here is that they can damage the vascular system, which causes that avascular necrosis that we're concerned about. That can actually cut off the blood supply to the femur and cause death to that bone, and also can turn into sepsis if we're not careful. So that's what we're concerned about when there's intercapsular fractures, is avascular necrosis. The extracapsular fractures are probably the most common. They happen right there in the trochanteric region, and that's between the base of the neck and the lesser trochanteric region. The thing about these is there's good blood supply, so they tend to heal more quickly. A lot of times these are the areas they can do the intermedullary nailing or the IM rodding. Whenever the fractures happen up in the intercapsular area, a lot of times they end up having to do a total hip replacement to correct it. Risk factors we talked about happen most frequently in elderly people, specifically people with low bone density from osteoporosis, and those who have a high tendency to fall, so people who have weak quadricep muscles, those with decreased cerebral arterial perfusion, like those who've had strokes, TIAs, those people on rural medications that maybe cause orthostatic hypotension, like cardiovascular medications and antihypertensive. So those people are going to be more at risk for hip fractures. We see them come in a lot, those patients that are nursing home patients who are, for all intents and purposes, immobile, yet then they come in with hip fractures. So they can always find a way to get out of bed. Signs and symptoms. We talked about with the intercapsular fractures, the leg is shortened, the affected leg is shortened, and it's adducted and externally rotated. So we said that it kind of looked like a little frog leg. The pain is specifically in the hip, goes into the groin. A lot of times these patients cannot move without having a lot of pain, and they're most comfortable when their leg is slightly flexed in that externally rotated position. You go to try to straighten it out, and it's extraordinarily painful. They'll say that they're in 0 out of 10 pain as long as they're not moving or that leg is flexed and in that externally rotated position, but you go to, say, put Buck's traction on them, and they're very in excruciating pain. The extracapsular fractures, you kind of have the same sign and symptom of the shortened, but it's actually more pronounced. It's going to be significantly shortened, and it's going to be externally rotated to a greater degree a lot of times than the intercapsular fractures. A lot of times there's bruising associated with this, and there's a lot of muscle spasms, and so it can be really, really painful. Diagnostically, a lot of times they come in, these patients come into the ER, and we just run a simple x-ray, and this is when the doctors see the fractures. Treatment, most oftentimes, is just surgical fixation of the fracture. A lot of times, though, we do put them in Buck's traction. The Buck's traction is basically you put a boot on the patient's affected foot. It kind of goes up to their foot to their mid-calf. It's a soft boot that's got a rope tied to the end of it and then a weight attached to that. You hook it up to a device on the bed, and it's going that traction, that weight is going to pull their leg straight, and it will help prevent muscle spasms a lot of times and can relieve pain. But really the traction is just used for that. And nowadays the doctors come and fix the fracture so quickly, there's times where we don't even have to put people in Buck's traction. But remember that anybody in Buck's traction, things you need to think about are pre-medicating them before you put them in traction, because it's extraordinarily painful. And also to do those neurovascular checks whenever they're in traction, because we want to make sure that we're not causing any neurovascular compromise. A lot of times these patients come to you from the ER, and one of the first orders as for the floor nurse is to put them in traction. The ER nurses do not do this. The doctor doesn't do it. It's the floor nurses that do it. So most of the time, the weight that they put on there is 5 to 10 pounds. Buck's traction, things you need to be careful of is to make sure the weight's not on the floor. So, because that will not keep your leg straight if your weight is sitting on the floor. So you want to make sure that your weight is hanging freely, not on the floor, and not inhibited by the bed in any way. We kind of talked about with surgical fixation that most of the time, as long as it's not a displaced femoral neck fracture, they will wait for like cardiac clearance and make sure all the family's involved in deciding if this is a good idea for the patient, because some patients are just not strong enough to go through surgery. But if the fracture is displaced in the femoral neck, they treat that more as an emergency because they're afraid of that avascular necrosis. After surgery, the goal is just to mobilize them very, very quickly. They can, by bearing weight on a stabilized fracture, it actually can creates more blood flow and can cause it to heal more quickly, and it prevents complications of surgery like DVTs and pneumonia and infection. The most common surgeries we do are open reduction with internal fixation. There's also hemiarthroplasty, where they can go in and do surgery on the joint. They can also do closed reduction with percutaneous stabilization, and that's usually those IM nailings or IM rods. What we need to be careful of with people who have surgery, and you're going to hear me say it over and over again, is neurovascular status. We want to make sure that we compare from one side to the other, that that their pedal pulses are present, that their capillary refill is less than 3 seconds, that they have equal sensation, remember that some of them are going to have nerve blocks, and that we need to take into consideration, and that they're able to move their toes or their foot or their leg with equal strength. Some people who have high risk for surgery, so they do not get clearance from, say, the cardiologist to put them totally under general anesthesia, they will do spinal anesthesia on these patients. So they will give them conscious sedation, and then they'll give them a spinal nerve block and do the surgery that way. They find that you have less risk whenever you don't have to intubate the patient under general anesthesia. Just remember, a lot of people who have hip fractures, yes, there are some younger people, but a lot of them are going to be your elderly people, like from a nursing home. It's just kind of that common patient I always think of. Complications are definitely, think of your respiratory complications. So atelectasis, pneumonia, they're not taking deep breaths. A lot of older people have a hard time with anesthesia, whether it's general or conscious sedation, and sometimes they're not as alert and oriented, don't follow commands as easily, so it's hard to get them to cough and take deep breaths. They're not as mobile, so that causes the same problems with atelectasis and pneumonia. If they do have that displaced fracture, they could end up with sepsis due to avascular necrosis, which is life-threatening. In addition, because of immobility, they could end up with DVTs, which can turn into pulmonary embolisms. They could have pressure ulcers because of immobility. Older people a lot of times can exhibit delirium, hallucinations, things like that after surgery. The fracture itself can have some complications. It can have a non-union where the doctors are trying to get to grow back together, doesn't. Also, there can be dislocations, specifically if they end up doing a hip replacement. Those hips can actually come out of socket and cause excruciating pain. And once this happens, it seems like it happens frequently. Like these people are in the ER frequently to get their hips popped back in the joint, which has got to be painful. Nursing interventions, for the first 24 to 48 hours, we really want to make sure our patients are pain as well under control, because we want our patients up and moving as best as possible. So whether they have a PCA pump or nerve blocks or an epidural, we want to be monitoring that to make sure that they're comfortable enough to move around. We want to prevent those complications like pressure ulcers and DVTs. Pressure ulcers, we might need to be turning our patients Q2 hours, maybe even more frequently. DVTs, we need to be keeping our SCDs and TED hose on. We talked about turning our patient. A lot of times we like to turn our patients on the injured side, especially if you've got a hip replacement, because that way it'll prevent possible dislocation, keeping pillows between your legs whenever you turn. There's some overhead trapezes that we can get, so people who are a bit more, that have some upper body strength, they can actually reposition themselves in bed by using an overhead trapeze. And remember our neurovascular checks. Wow, I keep saying that, don't I? A lot of times they'll have a Foley catheter in the first day or so, but after that they remove them, and that's kind of a twofold reason. One is to prevent UTIs, the other is because it promotes our patients moving around, because then they have to pee, so they have to move, and that just that helps them in many different ways by moving around. Prevents a lot of those complications of immobility. Okay, so we're through hip fractures. Let's talk a little bit about other fractures. Got a picture up here of some of the different types of fractures. Important ones to know, like that comminuted fracture. That's the one where the bone It's essentially splintered and it's broken to fragments. You've got those compression fractures. Those are the ones that happen frequently in people with osteoporosis, specifically in the vertebrae. It can have a lot of complications because your spinal cord column with nerves are running there. The green stick fracture is one where only one side of the bone is broke, the other side is bent. So if you think of it like a piece of wood that's living green wood, healthy wood, and you go to try to bend it and it only breaks on one side, it's kind of like that. Impact fractures happens a lot of times whenever people are jumping from things, and the fracture is because a bone fragment is driven into another bone fragment. So a lot of stress put on that joint, usually because of jumping or something like that. Open fractures. Open fractures are frequently called complex or compound fractures. And this is whenever the bone breaks through the skin or mucous membranes. These are the patients that I say, this is why I don't work in ER, because I want them all fixed up, bandaged up, bone back in place before I see them. This is kind of the part of nursing that grosses me out. Everybody's got something. This is one of those things for me. But these go from grade 1 to grade 3. Grade 1 is a clean and just a small puncture of the bone through the skin. So it's usually less than 1 centimeter long. That's a grade 1. So it's clean and less than 1 centimeter long. Then you've got a grade 2, which is a bit bigger, maybe not quite as clean, and grade 3, which is highly contaminated. These are the ones that are, fractured in a car wreck and got thrown from the vehicle, and their wound and bone is covered in glass and dirt and things like that. These are very, very high risk of infection and osteomyelitis. Pathologic fractures a lot of times happen with people who have bone cancer and tumors, and these happen just without any certain reason, no trauma. These are people that just have breaks because of some pathological process they have going on in their body. Simple fracture, it's just a clean break through the bone. It's also can be called a closed fracture as opposed to our open fracture, one line up in the middle. These don't cause a break in the skin. Spiral fracture is where the bone is twisted. Stress fracture, a lot of times those are from repeated injuries. So runners get this a lot. People walking a lot. Those people get stress fractures. So those are the types of fractures that I want to pay attention to. There's a few other ones you can read about. Most of the time, we always get nervous about doing the pathophysiology of fractures, and really just know that there's some sort of a blow or a force, so a direct blow, a crushing force, a twisting motion, maybe muscle contraction. There's some sort of a force that's causing the bone to break. Now, there could be some other reasons that are involved. A lot of times, you have to think about if they have osteoporosis or if they have tumors or things like that. But there's there could be something that's causing the bone to be weakened and less force needed to break. But a lot of times it's just some sort of a force that causes a break in the bone, and that's the in and out of that as far as the pathophysiology map. So it's defined as a complete or an incomplete disruption in the continuity of bone structure, and is defined according to its type and its extent. There's lots of different fractures, and we have different nursing considerations depending on where our fractures are. So I think if you have a patient who has a facial fracture, you're concerned about different things than if your patient has a wrist fracture or a pelvic fracture. So just remember those things. Signs and symptoms, pain and deformity and swelling are going to be your most common initial signs and symptoms. A lot of times that pain gets worse after about 20 minutes because of muscle spasms that are happening around the fracture. So the pain can intensify in those 20 minutes. Usually have a loss of function, so say you break your wrist, you're unable to open and close your hand anymore. That's common. Can have deformity. So I've seen some really, if you really want to look, you can Google it and look for some really interesting fractures where the the leg's going completely the wrong way, or the wrist is going completely the wrong way because of a fracture. Could have some shortening, as we see in those hip fractures. Could have crepitus, which is the pop, and snaps, and crackles that you can hear. Kind of like a crumbling sensation. A lot of people won't let you move it or touch it that much whenever it's really hurting to find that out. And then you can have the swelling and the ecchymosis, or the bruising. Diagnostically, we most of the time just use x-rays, but there's times when we need to have CTs or MRI, especially think about stress fractures and some of those smaller fractures you need to see with possibly an MRI. Treatment. Bone healing tends to take about 6 to 8 weeks. So if somebody asks how long it's going to take for my bone to heal, and it's just an uncomplicated fracture, the general answer is 6 to 8 weeks. Most important thing in emergency situations is that we want to mobilize the joints proximal and distal to the fracture. So if you break your wrist bones, you would want to immobilize your wrist and your elbow, most probably, to promote immobilization of those joints until they get it stabilized. Remember that if you're putting on some sort of a splint, say in the say you decide to work in the ER or an urgent care clinic, that you want to do neurovascular checks before and after splinting. We want to make sure that we're not causing any harm. There's lots of times where emergency room nurses, I can't feel bad blaming them. I'm not blaming them. I'm just saying that those are the ones who generally put it on and put splints on, and then by the time the patients get to the osteopathic doctor a week later, they'll already have some bruises or something due to the splint. Bruises or open or sores underneath that splint due to pressure points. So we have to be very, very careful when we're putting these splints on to make sure that we're not causing any neurovascular impairment. So you want to check for pressure points. You want to check your neurovascular capillary refill, definitely circulation. If you tell people if you have a cast on and the fingers start turning white or blue or numb or tingly, that you want to make sure to get that checked up with, because you could be causing some compromise to the circulation. Sometimes immobilization and rest is all we need. They've really gone to putting people in these like boots and splints and things that can come on and off a bit more easily. And that's, wearing that for 6 to 8 weeks will heal it up. But if the fracture's displaced, or if there's a big gap between the bones that's not healing, then, or if it's one of those like comminuted fractures where there's a bunch of bone fragments, they'll do a surgical reduction, which is the term that they use when they heal the bone, or when they try to get the bone to grow back together. The surgical reduction. It is the restoration of the fracture fragments to anatomical alignment and positioning. So you can do closed reductions, and this is through manipulation or manual traction. Some people have to be put under anesthesia for this to happen. Sometimes it can be done in the ER with our, we can manually reduce a fracture. But there are times when we need to put them under anesthesia and maybe put a pin in to keep the bones in alignment afterwards. An open reduction is whenever they go in and actually have to open up and look at the bone, and then they usually put in internal fixation devices. So that's where we get our name, open reduction internal fixation, or ORIF. Those internal fixation devices can include pins, wires, and screws, and plates, and nails, and rods, and things like that to keep that bone growing in the correct manner. After they do these surgeries, they generally put some sort of a splint on. The reason that they like to put splints on people with ORIFs versus casts is so they can quickly have a good way to look at the incisions. These days it's hard to look at incisions with those big casts on, and we don't know if it's infected or if we have any compromise sometimes if we aren't frequently looking at the incision, so they'll just put splints on people. But we really want to make sure that we help control swelling, because swelling equals pain. So you want to keep the extremity elevated, and whenever we say elevated, it generally needs to be above the heart to prevent swelling, and applying ice as prescribed. So doctors can get real upset if we as nurses don't keep those ice bags filled up. Isometric exercises. This is similar to our, think about back to our Kegel exercises. This is whenever you're working out a muscle by not moving a muscle. So it's not like lifting weights. This is like squeezing and letting go of your bicep. You know, with no weight, you're still working out the muscle, but you're not moving it or moving the joints. And this is a way that you can help prevent atrophy. If anyone ever has had a cast, or you'll know that whenever you take that cast off, that affected arm or affected leg or whatever looks much smaller than your other one because it hasn't been used, and the muscles can atrophy very, very quickly. So if the doctor's okay with it, we can teach our patients isometric exercises to help keep those muscles strong. If our patient has had one of these open or complex or compound fractures, we might need to be giving them antibiotics and the tetanus toxoid injection to help prevent infection, tetanus for lockjaw. The wound might need to be irrigated and debrided as they're doing the ORIF. We might need to look at doing a wound culture to make sure nothing's growing in there. There's times when we actually have to leave the wound open for several days, up to a week, to keep irrigating it to prevent infections, specifically with our open fractures. And at this point, we want to delay that primary wound closure. We want it to heal by secondary intention. We also, as nurses, need to make sure that our patients know how to use assistive devices. This is specifically with people who have lower extremity fractures. So we might need to teach them how to use a walker or a wheelchair or crutches. We need to be able to demonstrate that. So whenever we say to go in and watch physical therapy, teach crutch walking, this is real important because a lot of times these patients might come to the floor and leave before physical therapy has a chance to see them, or they come into the emergency room and it's the nurse's job to teach crutch walking. It's not always going to be a physical therapist there to do it. So whenever we say go in and watch your patient as they work with physical therapy, that's because that's where you can learn a lot. Learn how to teach people how to crutch walk. How to walk upstairs with crutches is real important to know. They might need to modify their home somewhat, so it's nice to know if they, live in a apartment complex and they live on the 3rd floor and they need to use crutches or a walker or a wheelchair. Like we talked about with joint replacements, is we need to know if our patients are non-weight bearing, if they're toe touch weight bearing, or if they're partial weight bearing, or weight bearing is tolerated before we get them up or move them at all. And remember, this weight bearing status goes for upper extremities too. Things can be non-weight bearing or partial weight bearing with upper extremities. So remember that. We also need to elevate that extremity, teach our patients about using ice at home, assess for signs and symptoms of infection. there are times when, and it happens so infrequently these days, didn't really touch on it too much, but there's times when patients need external fixators. And external fixators are happen whenever you have a patient that's got a fracture that there's nothing, it's like usually there's not enough bone left or something like that for them to put internal fixators like pins and screws and things like that. So they'll put external fixators, and these are the ones who walk around with like the big cage looking thing around their leg, and those external fixators are keeping the bone in place so it has time to heal. And at that point, there's pins that are driven into the skin from the outside into the skin, into the bone. And so we want to make sure to teach our patients about pin care, because we want to make sure that they don't get those sites infected, because that can cause osteomyelitis or infection in the bone. And we're really concerned about that. Complications of fractures. We touched on this. We've got our picture down there of our guy who's had a fasciotomy, who had compartment syndrome. But one of the biggest fracture complications we're going to be worried about is actually the fourth one, which is DVT, and that's because it leads to PE, or pulmonary embolisms. But we'll start at the top, talk about shock. We're worried about shock mostly in patients who are hypovolemic, so we think about people who have crush injuries like to their pelvis, so pelvic fractures, and open femur fractures because they can tear the femoral artery, and they can lose blood very, very quickly. So we're concerned about shock. We're going to learn more about shock when we hit Adult Health 3. Our goal for these patients are to quickly stabilize their fracture to prevent more trauma and to restore their blood volume with volume expanders or blood products. Next is fat embolism. It talks about how fat embolisms happen frequently with those who have fractures of their long bones or their pelvic bones or crush injuries. So you think about people who are in car wrecks. These happen more frequently in people, men specifically, sorry guys, younger than 40. They can happen more frequently in those who've had multiple fractures. This is when fat escapes from the bone marrow and gets into our vascular system. The fats then include blood vessels, and this can happen anywhere from 12 to 48 hours after, and up to 10 days after the initial fracture. Our patients kind of get the same signs and symptoms as a pulmonary embolism. They get hypoxic, their respiratory rate increases, their pulse increases, so tachycardic. They can run a little fever, but a lot of times we see that respiratory distress, shortness of breath, crackles, wheezes. People get restless. They say something just doesn't feel right. They could have early respiratory alkalosis, which turns into respiratory acidosis as their body is no longer able to compensate. Whenever they look at a chest x-ray, all they'll see, chest x-rays, you're supposed to just see black and ribs that are white for the most part. And heart usually looks kind of white, but what they'll see in these chest x-rays are just pure white chest. So chest x-ray shows a snowstorm. So they're essentially losing all of their ability for gas exchange, which is not compatible with life. One of the things that is specific to fat embolisms that you can see is petechiae, specifically across the upper chest, the buccal membranes, so inside the mouth, and the conjunctival sacs, sometimes over the hard palate. So we're really concerned about that whenever we see those petechiae in someone who's saying they're short of breath and they have a history of a fracture, specifically one of these crush fractures. Ways to prevent this from happening is if we immobilize quickly after a fracture. So We don't want to be moving a patient around a whole lot who has a fracture because it could dislodge one of these fat embolisms. The only thing we can do if they get this is manage their airway, manage those in their respiratory system, and try to correct their homeostatic disturbances. So we want to correct their fluid volume and their ability to exchange O2, support that usually by having them on a ventilator until the body is able to absorb and restore its own homeostasis. Not a lot we can do when people get this. Very dangerous. The third one is compartment syndrome. Compartment syndrome is specifically happens a lot with fractures. Our compartments in the body is an area of the body that's encased by bone or fascia. That fascia is that non-pliable, non-elastic coating, I guess, that covers our tissues and our muscles of our body. The human body's got about 46 compartments, and 36 of them are in our extremities. So a lot of them in our extremities. Compartment syndrome happens when perfusion pressure falls below tissue pressure within a closed anatomical compartment. So basically, the swelling gets to be so bad that we're no longer able to get perfusion or circulation into that area. So you can see how without getting circulation to an area, that area could die off quickly. So in acute compartment syndrome is a sudden decrease in blood flow to the tissue distal to an area of injury, and it can result in ischemic necrosis. So ischemic means no blood flow, necrosis, death. One of the most common signs and symptoms of this is a deep throbbing pain. So you can give them pain medication and the patient's still complaining of pain that seems like an abnormal amount of pain for, maybe they just, broke their radius, but they've got abnormal amount of pain despite giving them medication. The hallmark sign of this is important to know, is that pain occurs or intensifies with passive range of motion. So the pain is going to get worse and worse and worse. You give them medication, it continues to get worse. You do passive range of motion, and it's just excruciating. This is an emergency. Our goal as nurses is to prevent tissue death, so we're going to try to decrease the swelling, which we know we could place ice or elevate the extremity, but we want to call the doctor very, very quickly. When we talk about neurovascular assessment or neuroassessments after the fractures, we a lot of times like to talk about the 5 P's. So P as in Paul, which is pain, paralysis, paresthesias, pallor, and pulselessness. So things we ask our patient. Number 1, are you in pain? A lot of times they are, but is it look, this picture we have on here, this guy looks like he'd be in pain. We'd understand if he's in 10 out of 10 pain. But if it's just a simple fracture or something that, doesn't look like it would hurt too much, and it's just excruciating for a patient, that might be a key, something that triggers our minds to this. Paralysis, are they unable to move the extremity? Paresthesias, are they feeling like pins and needles? Pallor, is it whenever you check capillary refill, is it greater than 3 seconds, or do the fingers look white or blue? Pulselessness, there's no pulse. You check and there's strong radial pulse on one side and not a radial pulse, or only a +1 on the other side. That could be a problem. That is a late sign. So we don't want it to get to no pulse before we catch this, because by then we'll probably already have some tissue death. On palpation, if we feel over the spot of this compartment, you a lot of times feel a muscle that's swollen and very, very hard, and that's from all that swelling. And all that swelling is cutting off the circulation. Treatment, our conservative type of treatment is anything that's going to help restore tissue perfusion and relieve pain. But if about after an hour, if our normal treatments such as elevation and ice and pain medication does not help, a lot of times doctors will go in and do a fasciotomy, which is where they remove the fascia over that muscle. So this is the picture we have up here. Fasciotomy is done. The wound is left open a lot of times. We usually splint the area. Elevated above the heart. They'll perform passive range of motion just to try to get blood circulation flowing in there. After about 3 to 5 days, they'll go ahead and close. They'll debride any dead tissue, and then they'll close the wound. They're at very, very high risk for infection when that wound's open like that. But there's no reason to close it up because it can cause more swelling and more problems with pressure differences, which can cut off our circulation. And also, they want to be able to take out any dead tissue that they see before they close it up. DVTs, I know we've talked extensively about DVTs and ways to tell a patient has a DVT. You always want to compare lower extremities. The patient complains of pain to their lower calf. If the one calf looks bigger than the other, if one's red and swollen and hot, patient complains of pain, then we're concerned that a patient has a DVT. The reason we're concerned about patients with DVTs is because that thrombosis can break off and become a pulmonary embolism, which can then be a medical emergency and can sometimes cause instantaneous death. Pulmonary embolisms deaths can occur several days to weeks after. So this is not just something we need to stress while we're in the hospital, but it's something we need to teach our patients to be moving around and the signs and symptoms of DVT and PE before we discharge them, because they need to know if they have any signs and symptoms of DVT or PE that is an emergency and they need to go straight to the hospital. We know that ways to prevent DVTs are to give medications like Lovenox, heparin, Coumadin, which are in that category that we like to call blood thinners as nursing students. But the other thing we can do is SEDs, TED hose. Early ambulation is the most effective, I would say. But as Bill from St. Joe's Joint University was talking about, there are some people that just develop them no matter what we do. But we want to do our best as nurses to prevent this from happening. Okay, osteomyelitis. Osteomyelitis is an infection in the bone. Osteo means bone, myelo means marrow cavity, and itis is inflammation. So I always think of it as like a bone infection. It's a severe infection of the bone and local tissue, and it requires immediate treatment. Etiology. The reason why we talk about this is because osteomyelitis can happen for several different reasons, not just the most obvious, which is you think about people who have like open wounds, they can get osteomyelitis, or like open fractures, they get osteomyelitis. But there's some other people too, so we're going to talk about that. The first kind of osteomyelitis is hematogenous osteo. 70 to 80% of these cases are caused from Streptococcus aureus or a gram-negative bacilli. That's Haemophilus influenza. These happen frequently with patients that are younger than 3, so 2 months to 3 years old. This is an indirect form of osteomyelitis. So say a patient has an infection of Streptococcus aureus, the bacteria will travel to a bone in the body and cause this osteomyelitis. So it might not be that they, have an open fracture and that's how the bacteria or infection got in. It might be that they had an infection and this is where the bacteria kind of ended up. So this is the indirect form. Happens more frequently in children. Or people with chronic skin infections, UTIs, or IV drug use, or especially think about people who are immunocompromised. It can affect the growing bones in younger children, so you have to think about that. So that was hematogenesis osteomyelitis. The next one is a contiguous focus. This happens a lot of times with people who've had open wounds. So think about patients who've had burns or traumas or periodontal infections. So those are like people who have a toothache and they don't ever go see the doctor. Or people who've had pressure ulcers. And this a lot of times is Streptococcus aureus, and sometimes it's a gram-negative or anaerobic bacteria. The next kind is direct osteomyelitis. This is usually the ones that's a result of an open fracture or some sort of penetrating wound. That so people get stabbed, or they're in a car wreck and there's an open fracture. Or surgical contamination, so if they have like a knee or hip replacement, prosthesis is put in, metal plates or screws. This a lot of times is from a direct result of bacteria being placed into the bone. If none of these are treated quickly enough, it can quickly turn into chronic osteomyelitis, which is osteomyelitis. We're going to talk a little bit about it when we get into the pathophysiology. But chronic osteomyelitis a lot of times is this bone infection that will actually destroy the bone to where it's no longer functioning healthy bone. A lot of times caused by strep or staph also. Risk factors. So our risk factors, some of it we talked about there with our etiology, that people who've had chronic skin infections, UTIs, IV drug use, or immunocompromised can get that indirect or hematogenesis osteo. Those who've been burned or have had traumas or had periodontal infections or pressure ulcers can get contiguous. So you think about your patients that are at risk for those. Direct risk factor, people who have direct osteomyelitis, those risk factors are those who possibly have osteoarthritis, because a lot of times they get prosthesis put in, but also those who are in high risk type, high risk people who maybe take a lot of risk taking, and they can end up with fractures where they need screws and plates and things like that. So those are our risk factors of osteomyelitis. You'll see a lot of people who are diabetic get osteomyelitis because they've got a lot of wounds that don't heal and ulcers. So they get a lot of those contiguous focus osteomyelitis. Pathophysiology. Basically, our organisms, our bacterial organisms, most frequently, our bacterial organisms reach the bone by one of three routes. So we've got number one, our hematogenesis osteomyelitis. They reach the bone by bloodstream. This is the most common form. Number two, they can reach the bone from adjacent soft tissue, which this is our contiguous focus. Number three, the bacteria can reach the bone by direct introduction of the organism into the bone. In our acute stage, so after the bacteria has reached the bone and it starts to multiply, the bacteria get in the bone and they proliferate. So they get in the bone and they just grow like crazy. In children, a lot of times this happens in the growth plates because that's where there's a lot of blood supply. Then our body mounts an inflammatory response, and that's when we get pus and edema and a lot of blood or vascular congestion going into that area because our body's trying to send white blood cells and things like that to get this infection. So then the pus collects, and it's confined to the bone, which can increase pressure around and in that bone, which can then lead to vascular occlusion because of the excess pressure put upon the vasculature of the bone, which can then lead to ischemia and necrosis of the bone. Now, one other thing that's important to know is that our antibiotics can't always reach inside the bone, which is why it makes osteomyelitis so hard to treat. So a lot of times the bacteria might sit there, we might get a lot of the infection killed, but there still might be bacteria deep inside the bone. And that's why a lot of times the infection can reappear years later, or if the patient becomes immunocompromised and the bacteria start overgrowing. Problem we have with having necrotic bone sitting there is that it separates from the healthy bone in dead segments called sequestra. This dead bone or sequestra is then a medium for more bacterial proliferation. And with dead bone, no blood supply, it's really hard for our antibiotics to reach this bacteria. And this is when we end up with chronic osteomyelitis. So a lot of times with chronic osteomyelitis, the sequestra get bigger and bigger. They go through healthy bone. They grow so big it gets into our healthy bone. It goes into our soft tissue. And it can cause sepsis, ultimately, because the bacteria just start spreading and growing. Acute osteomyelitis, they say it's in the acute phase if it lasts 6 to 8 weeks. If it lasts beyond that, they usually call it chronic osteomyelitis. Another thing that differentiates acute from chronic, usually once you start seeing those sequestrum, they'll call it chronic. Another thing that can happen is that a new layer, our body's got those osteoclasts that are breaking down bone and osteoblasts, which are forming bone, and our body can actually form new bone around that old dead bone because the osteoblasts are trying to heal the infected bone, and that makes it even harder for the antibiotics to go in and kill that infected bone inside the new bone. And that leads to chronic osteomyelitis. The bones generally affected in osteomyelitis and the hematogenous osteo, it's mostly bones that are rich in red bone marrow. So think about your long bones in kids, like your femur, your proximal tibia, your humerus and radius. In adults, a lot of times it's our vertebrae, our sternoclavicular bone, our sacroiliac joints, our symphysis pubis, our tibia. So they're bones that are rich in red marrow. In contiguous spread, any bone can be infected. And in direct, it's whatever bone is that's been directly punctured or broke. Risk factors most often happens in our young children, so less than 16, and that's our hematogenesis osteo, or greater than 50, and this is a lot of time with that contiguous spread because you think of people with chronic diseases like diabetes. So less than 16 or greater than 50 with some form of vascular insufficiency. So those are people with diabetes or peripheral vascular disease that can have a hard time getting blood supply to those areas to heal up a minor infection, which can turn into a major infection. Our signs and symptoms in children, a lot of times there's high fever and there's pain at the bone site. They can also have, in young children where they actually refuse to move a limb. So they're, your child is always writes with their right hand, and all of a sudden they've been, eating and writing with their left hand, and you don't know why, and it's because it hurts when they move it. And it might be swollen or red. It might be having some muscle spasms in the area. So it's a little bit easier in children because, the pain becomes localized at the bone site. In adults, there's generally more vague symptoms. So you might see some fever, or malaise, or anorexia, or night sweats, or weight loss, pain. So some of the problem there is, that kind of looks like the flu. It could be tuberculosis. It could be a cold. It could be many, many things, and adults tend to write that off. So that's some of the early symptoms, and then eventually they'll end up with, this is especially with the hematogenesis spread. Whenever they have indirect or direct osteo, a lot of times we're already starting to worry about an area. So if they had an ulcer, they'll start having pain with movement or loss of movement, some localized tenderness. Might have poor wound healing. So if you think about like those who have prosthesis because of a hip or joint replacement or something like that, their wound just doesn't heal. It could be they're draining or separating at the incision site. So in those people, it's a little bit easier to diagnose than with a hematogenesis osteo, which is more of the indirect, because they're going to have more vague symptoms. It's hard to figure out exactly where the bacteria have started growing. Diagnostically, on x-rays, what they're looking for is bone destruction. A lot of times they're going to have to see it from MRI because they might not see it initially from x-rays. So they might not even see anything until about 10 days after you start having those clinical symptoms that we just talked about. So they can do MRI, they can do a nuclear bone scan, and these scans can show changes more quickly, so 10 to 14 days before x-rays. So a lot of times if doctors are concerned about a patient having osteomyelitis, they'll do a bone scan or they'll do an MRI to try to confirm. And they might just follow up with x-ray a week or two later, because a lot of times those initial x-rays aren't going to see anything. They could actually go into the bone and try to aspirate cultures. They could look at the blood and aspirate and look for blood bacterial cultures to see if there's any sepsis. As far as complications, things we're concerned about is definitely septicemia, which can lead to which is sepsis, which can lead to death. Could have septic arthritis, especially if you've got some osteomyelitis around the bone, around a joint. You could have pathologic fractures. So, say you've got osteomyelitis in your femur, you could just end up with fractures in your femur, which can be very painful and dangerous because you now have ischemic necrotic bone that's replaced your healthy bone. In children, you can have problems with growth because it can actually affect the growth plates, and the bone's not going to grow properly. Treatment-wise, we want to rest that limb. So we want them non-weight bearing. We want them immobilized. That's going to help it heal. This is something different than what we've talked about with most fractures, where we want people moving and blood flow going. We don't want the bacteria to start really being carried away by our bloodstream and causing sepsis. We don't want more blood flow there, which is going to cause the bacteria to start growing more. We need just enough blood flow to get the antibiotics there. So you want them to restrict weight bearing. You want them to, or non-weight bearing. We want the area to be immobilized. We want to treat them real quickly before they have more bone destruction. The patient might need debridement of the area, so that's surgically where they go in and cut out some of the dead area. They might need drainage of the area, so it could end up being like an incision and drainage. A lot of times it's very painful, so we're going to need to treat our patients with pain medication. Ultimately, what treats them, though, is IV antibiotics, long-term IV antibiotics. We try to choose them based upon culture and sensitivities. So they will try to see if they can identify specifically what bacteria is causing the problem. And then based upon what that is, they'll choose a course of treatment. So like 4 to 6 weeks of IV antibiotics. And then once they get off that, they usually do oral antibiotics until they're sure that the infection goes away. Because remember, these infections can show back up quickly. Just as a note, sometimes the patient's white blood count is not elevated because the body is not able to mount an attack. So you might not have an elevated white blood count or even a SED rate. It just depends if the body actually knows that there's a problem and if it's able to do anything about it. Okay, back to treatment. So IV antibiotic is our treatment of choice, along with immobilization of the affected area. Other things they can do are put antibiotic beads. So these are antibiotic impregnated bead chains, usually with vancomycin or tobramycin, that can be embedded into the cement and placed into the area that has osteomyelitis. Another thing that they can do is hyperbaric oxygen. This has kind of been a new thing with wound healing. So with some specific forms of osteomyelitis, people who have poor circulation and they need a little bit more blood flow to get antibiotics to a certain area, the hyperbaric oxygen can help stimulate that circulation and healing of the infected tissue. If there's an abscess or if there's an area of bone necrosis, a lot of times they need to surgically remove that by debriding. And there might be pus in the periosteal area, and they might need to remove that. If there's a prosthesis, like a knee replacement or a hip replacement, they're probably going to have to remove the prosthesis. And when they do remove this prosthesis, especially with knee, a lot of times I've seen them put in antibiotic spacers. So instead of having a knee joint, because they've had to remove that, they don't want to go ahead and put another knee joint in there while they're waiting to clear up an infection, so they'll just put an antibiotic spacer in and have to have the knee totally immobilized because the joint has been removed. They'll have to have it totally immobilized until usually 4 to 6 weeks they complete the IV antibiotics before they'll be willing to put another knee joint in there. I've seen it with several patients, and it's real sad. It's a long, slow process to get these healed up. If you've got a patient with osteomyelitis and peripheral vascular disease, which is very common with your diabetes patients, remember, because they get ulcers easily, and a lot of times because of macrovascular complications of diabetes, they have peripheral vascular disease. They might not have enough oxygen flow to get any antibiotics, might not have enough circulation to get antibiotics down to the area it needs to be, and so sometimes they have to do amputations to remove this area of osteomyelitis. So this is one reason why we end up with people with diabetic ulcers, specifically on lower extremities. They'll get gangrene or they'll get osteomyelitis, and that's why we have to do amputations. Remember that if we send people home on antibiotics, long-term antibiotics, we're going to need to put in some sort of long-term IV access. This is generally in the form of PICC lines because PICC lines or peripherally inserted central catheters tend to be easier to care for in a home setting than regular central lines. A lot of times these people go home with home health or some sort of skilled nurse or to a skilled nursing facility for 4 to 6 weeks, up to 3 to 6 months. So this can be a long, slow process. Usually they're going to monitor these patients with bone scans, or if they're and they'll probably draw a erythrocyte sedimentation rate, or an ESR, which is a blood test that tests for inflammation. Like I was saying before, sometimes it's not elevated because our bone's is not able to mount an inflammatory response, but sometimes it is, and so it's worth just testing to see if it's, elevated, if it is, if it's getting any better. But bone scans are going to be the easiest thing to monitor osteomyelitis from. Prevention. It's very important that that doctors and healthcare providers follow strict operating procedure protocols to prevent infections, specifically like in operating rooms, and dressing changes whenever we're doing dressing changes on like knee and hip replacements, people who have hardware put in, because any bacteria that can get into that infection will colonize and grow on that prosthesis and can cause osteo. It's also important that we give prophylactic antibiotics, especially any patient going under bone surgery. So that's something that we should expect as a nurse. No, we can't order it, but we can remind a doctor to order it if he doesn't. And immediately, patients after surgery generally are given antibiotics up to 24 hours after. After 24 hours, we usually stop these prophylactic antibiotics because they found evidence-based practice has shown that it has not helped outcomes, and it's actually just caused more complications if we continue after 24 hours. But a pre-op dose is generally given, and doses are given up until 24 hours after surgery to prevent infection. Very important to use sterile technique when working with our drainage tubes or dressing changes, and that will help prevent infection. If you think about some nursing diagnosis for these patients, you've got a possibility of acute or chronic pain, depending on what kind of osteomyelitis they have. Definitely some impaired physical mobility, possible hyperthermia, fear, ineffective self-health management, because they have could have a lot of learning to do on how to care for a PICC line and give themselves IV antibiotics. Possibly risk for constipation because they're going to be on long-term. They're probably going to be on some pain medications because it's very painful, and they're not going to be moving around possibly as much as they have been. Risk for infection, even more infection than they have. Risk for impaired skin integrity. We need to give these patients a lot of teaching, especially upon discharge, because we don't want them to experience those complications of osteo like sepsis. We don't want them to need amputation or things like that. So it's important to give a lot of teaching to our patients. Teach them about controlling infections, especially those that come from osteo that comes from indirect sources like urinary tract and respiratory tract infections. We want to teach them about controlling those infections. We want to teach them about signs and symptoms of osteo, especially if they're at high risk because of knee or hip replacements or open fractures. We want them to be able to know to report signs of symptoms of bone pain and fever and swelling. Need to teach them about immobilization of their joint, of their affected area, because this decreases pain and decreases pathologic fractures, and hopefully help with the prevent more spread of bacteria. We're probably going to treat with NSAIDs and opiate analgesics for short term, sometimes muscle relaxers, and also our non-pharmacologic pain management techniques, guided imagery, hypnosis. We might be doing dressing changes, so patients would need to learn about that. If our patients are going to end up on bed rest for any reason, we want to prevent contractures, we want to prevent respiratory issues from immobility like atelectasis and pneumonia. We want to prevent ulcer formation, so we want to teach them about position changes. We want to avoid any activities that are like exercise or heat that are actually going to increase circulation. We need just enough circulation to get the antibiotic there, but not enough to spread our bacteria. There might be some side effects because of the long-term antibiotic use. Think about C. diff, which happens when we kill off the good flora in our gut. It can also be yeast infections, thrush, whenever people are an overgrowth of our overgrowth of normal flora because of antibiotics. So we want to teach our patients to report any whitish or yellow-like curd-like lesions in their mouth, or for women, like yeast infections. When patients are on some of these antibiotics, long-term IV antibiotics like vancomycin, gentamicin, tobramycin, a lot of times they're going to need peak and trough levels drawn. Peak levels are generally drawn. Actually, from what I was talking to some doctors, they're not doing peak levels as frequently, but peak levels are usually drawn about an hour after medication is administered, and it's checking to see what the amount, how much drug is in your system an hour after you get the drug. So it's a peak amount of drug in your system. The trough levels, they say, is what they're mostly going towards, and trough is what's showing how low are the levels getting in your bloodstream, because what we're concerned about is to make sure that we are in a therapeutic range. So trough level for medications are generally drawn 30 minutes prior to the next administrative dose of the antibiotic. So say our vancomycin's due at noon, they'll draw a trough level at 11:30, and we're looking for it to be within range. If it's high or low, we need to contact the doctor to alter or hold the dose, depending on if it's high or low. We need to teach our patient about how it's important to administer their antibiotics properly when scheduled, because it's going to prevent super infections from happening. So they need to learn to take their medications at the correct time and to complete all of their dose of medications. Also might need them to teach them about management of their venous access device. Okay, just two more things here. Sorry, my screen's falling asleep here, as I'm sure y'all probably are too. Try to
speed me up, okay? Okay, low back pain. Low back pain is something that's very important to us as a profession, because nurses historically end up with a lot of back pain. We are a very active profession. We're moving and pulling and pushing and tugging on people. Sometimes people that are hard to move. So whether they weigh a lot or they're what we like to call, like dead weight, they're just not able to help a whole lot. And we are, as nurses, are givers, and we just want to help people, and sometimes we don't take care of our back. So this is something that's very important for us. The problem of low back pain is a big problem recently. Some of the studies have shown that the number of visits to primary care providers for low back pain is second only to upper respiratory infections. So it's just a big, big problem. Most of our causes are going to be acute lumbosacral strain. So if you think about your vertebrae, you've got, when we talk about low back pain specifically, we're talking about the vertebrae in the lumbar and the sacral region. Most commonly it's L4 to 5 or L5 to S1. So you could have strain in that region. You could have unstable lumbosacral ligaments. You could have unequal leg strength, so one leg stronger than the other, which is causing an imbalance. You could have weak muscles, specifically
those core muscles that you've been hearing all about we need to strengthen. And you can have intervertebral disc problems, such as bulging disc, things like that. Could actually have osteoarthritis of the spine, so that's our degenerative joint disease, but of the spine. Could have spinal stenosis, which is narrowing of the spinal column. Could have osteoporotic vertebral fractures, which causes problems, as we've talked about. Some of our risk factors are obesity, poor core strength, stress, depression, and people who are risk takers, so people who are moving and pulling and tugging on things they should not be doing, or people who are not lifting the boxes the way they're supposed to with their legs and not their back. Signs and symptoms. They can have problems with their gait, so troubles walking. They could have legs that are different length. They could have different leg motor strength. They might have sensory perception altered. And then the obvious where they complain of pain to their back. A lot of people who I see with low back pain say they've got, the pain in their back, but then it radiates somewhere. A lot of times down a leg, or causes numbness down a leg or something like that. Problem is, people who start having back pain end up with, it's just something that never really totally goes away. So you have to be very careful to protect your back, especially in this profession where we do need our back. We need to be able to move and do things. Pathophysiologically, we're mostly, like I said, concerned about L4 to 5 and L5 to S1 because these areas subject to the most mechanical stress. So we could have disc degeneration, we could have herniation of those of the area. Remember that your spinal column is held together by an elastic rod. This elastic rod is made of vertebrae, intervertebral disc, and they're held together by facet joints, ligaments, and paravertebral muscles. It's flexible, and we need it to be flexible because it needs to really support a lot of body weight. It's got to provide some shock protection. Remember that our muscles in our abdomen, our muscles in our truncal area, help stabilize our spine. So if those muscles are weak, we are at risk of having back problems. People who have poor posture, which probably all of us do to some extent. Also, you can have people with obesity, structural problems that will, definitely put them at higher risk of causing problems to the spinal or having problems with the spinal column. They call it acute pain if it's been painful for less than 3 months. After you have pain for 3 months and you have fatigue associated with it, they'll call it chronic low back pain. If you have any of that numbness or pain shooting down the legs, so radiculopathy or sciatica, it suggests that there's some nerve root involvement to your back pain. So sciatica is where you have that your sciatic nerve that is usually pinched or inflamed, and it's causing pain and numbness. Generally, people will describe as kind of a pain in their butt that goes all the way down their legs. Some people say all the way to their toes. It can be very, very painful. Diagnostically, well, we can look at x-rays, see if there's any fractures or see if there's any, big structural deformities. They can do a bone scan, look in more detail at the bones, which is a nuclear medicine scan. They can do CTs and MRIs. MRIs are one of the most common ones. They can also do myelograms. Myelograms specifically are going to look at kind of the muscle area and the tissues around the spinal column and less of the vertebrae. Treatment, we give analgesics. Remember that people who are in chronic pain, we generally don't like to give opiate analgesics because of their addictive nature, in addition to all the side effects associated with them, constipation and sedation. So think more about NSAIDs and muscle relaxers. They do give opiates on occasion. They found that steroids don't help a whole lot, so a lot of times you will not see steroids being given. Rest is going to be really important. The use of heat, so a heating pad is important. Some people do go for spinal manipulation, like with a chiropractor, acupuncture, acupressure, massage, yoga. You're going to find people doing all sorts of techniques to help with their low back pain, because this is one of those things that can really cause a lot of problems. We want to teach people to avoid twisting and bending and lifting and reaching as best as possible while they're trying to heal. It's important to change positions frequently, as this is going to prevent a lot of the, especially people with nerve issues associated with low back pain, it's going to prevent a lot of the numbness and tingling and pain because of that. They say sometimes that the best way to prevent low back pain is to, like this was saying, definitely prevent it by picking up things the proper way, like bending at your knees and not at your back to pick up heavy boxes. And I've even heard if you're going to be standing for a long time to like pretend like you, or to have like a box in front of you, and you can have one foot up on the box for a few minutes and then switch to the other foot up on the box. You know, that way you're helping get pressure off of your back. Some people who have back problems say just, you know, they can't stand for long periods of time. So, okay. Lastly, we're going to talk about rotator cuff injury. This is real important because I think it's becoming kind of more prevalent. We're hearing a lot of people who are having rotator cuff injuries and they have to go get their rotator cuff surgery. So you might see some of these at the hospital, but a lot of times they're done in an outpatient setting. Remember that our shoulder is a complex series of joints. The reason why it's kind of a complex series of joints is that it's got to have extraordinary range of motion. So think about your shoulder joint and which directions you can lift it up and down and turn it all around. And problem is, with all this extraordinary range of motion we have, it is not the most stable joint. So the range of motion is at the expense of stability. So instability and the exposed position of our shoulder joint makes it very vulnerable. So the fact that it is, you know, we land on this joint a lot, or we could land on this joint frequently, and it's very unstable, we can have injuries to our shoulder. Our shoulder is composed of our scapula, as far as bones, our scapula, our clavicle, and our humerus. The joint is actually made up of 3 different joints. One at the a joint at the acromion process and the clavicle. So the acromioclavicular joint, the glenohumeral joint, and the sternoclavicular joint. So 3 different joints. It's got 3. It's also composed of 4 different muscles in the shoulder: the supraspinatus, spinatus muscle, the infraspinatus, the teres minor, and the subscapularis muscles. Sorry if I mispronounced any of those. I can't remember from my anatomy how you say supraspinatus, but I do remember what they look like, crazily enough. So you're going to have 4 different muscles in that shoulder. All these muscles, the joints, and the bones make up your shoulder joint. So these muscles act to stabilize the humeral head and the glenoid fossa while assisting with range of motion of the shoulder joint and rotation of the humerus. So look, if you're looking at the shoulder, it's not like your hip where you have a ball and socket. You essentially just have all these muscles and some bones and some tendons and ligaments that are trying to keep this whole joint together. And this is called the rotator cuff. So degenerative changes of the rotator cuff may be associated with normal aging. However, a lot of times it's associated with repetitive stress to the joint. So if you think about people who do a lot of things with their arm over their head motion, so like swimming or tennis or baseball, they a lot of times have rotator cuff injury. Or people who have injury, so like they fall with their arm outstretched, or they hit their arm or have a blow to their upper arm, or they're lifting heavy things, or they're having any sort of repetitive work motion. So people who swing hammers, they're at risk of rotator cuff injury. The injury could be usually it's like a little tear. It could be a complete tear, and depending on what kind of tear around the muscle it is what kind of treatment they need to do. Signs and symptoms is weakness to the joint. A lot of people say that they can't lift their arm, up above their shoulder. Once they lift it above their shoulder, it's weak and they can't. There's no strength. So weakness, pain, decreased range of motion. Can be severe pain when the arm is abducted between 60 and 120 degrees. They can have pain at night. They can't get comfortable with their arm. They can't sleep on that affected side. And one of the most telltale signs is they can't perform activities over their head. So, if they went to try to maybe paint a wall or something like that, once they get their arm up over their head, they can't lift, or they have no strength in it. Diagnostically, they can look at it with an MRI and confirm if there's a tear. But an easy way doctors do it in the office is called the drop arm test, and this is when the arm falls suddenly after the patient is asked to slowly lower the arm to the side after it's been abducted 90 degrees. So the doctor will abduct their arm to 90 degrees, so they'll remove it, they'll move it away from the body to a 90-degree position, and then you tell the patient, okay, slowly lower it down, and their arm just drops. They have no strength and no control over how fast they lower their arm. This is kind of a telltale sign of rotator cuff injury. Treatment-wise, if it's a partial tear or just a minor little tear, we can treat it conservatively with ice and heat. We could do steroid injections, definitely some rest, NSAIDs, and then we usually get physical therapy involved, and they'll gradually start mobilization with range of motion and strengthening to try to strengthen up those muscles. And the goal is to maintain passive range of motion and return that abduction strength. If there's a full tear, or if it's just become, not being treated significantly with conservative treatment, they'll do a surgical repair. So they'll do a rotator cuff repair. If most of these surgeries are arthroscopic, so they're able to go through and just do it with scopes. When they're extensive tears, they might have to do an acromioplasty, which is surgical removal of part of the acromion, and that's going to help relieve some of that compression of the rotator cuff. These surgeries are very painful. You can ask Miss Conley. Her husband had one. But the thing you need to know nursing-wise is that we want to control their pain, and we want to help them manage post-operatively and teach them about post-operative treatment. Specifically, that their arm is going to be immobilized
generally immobilize for days to 4 or 5 weeks, depending on what their doctor likes. Even when they are able to start moving, they can only do very, very limited shoulder movements, and this is usually what they call pendulum exercises, which is where they get their arm out of the sling and they slowly let their arm hang, and then they start kind of swinging it like a pendulum. And this is about the only time they can have their shoulder immobile or out of the immobilizer for the first few weeks after surgery, because again, this rotator cuff is very, and their shoulder joint is very unstable, and the repair they did is going to cause problems with the stability of the joint. So they want to make sure that it has a chance to heal before people start moving it. Problem is, some people, if they're immobilized too long, can end up with what's called a frozen shoulder. So scar tissue and things like that can start growing and cause decreased range of motion with the shoulder. So you really want to watch for that. Once they start physical therapy, it's kind of the same goals as those who are in physical therapy for a partial tear. We want to increase or at least maintain their range of motion, and we want to get them to return that strength back to their arm. Usually full recovery can take up to 6 to 12 months, so it's a long, slow recovery process. I just want to recommend that everyone read their book about these few things that we talked about. And sorry you had to listen to me go on and on and on about these things. And good luck on y'all's test coming up.